The American Speech Language Hearing Association is pleased to welcome you to this online education program entitled Applying Swallowing Physiology to Diagnosis and Treatment Decision Making. Here with us today is Jenna Johnson, Associate Director of Healthcare Services and Speech-Language Pathology. Jenna, welcome to the program.
Thank you, Jill. Hi and welcome, everyone. We'd like to welcome Dr. Ianessa Humbert to present with us today on applying swallowing physiology to diagnosis and treatment decision-making. Before we start, Dr. Humbert, let's talk a little bit about why we planned this webinar. I know you have a plethora of experience in adult dysphagia as a clinician, an instructor, and researcher, and I know you'll be presenting this at our upcoming ASHA Healthcare Connect conference in July in Baltimore, Maryland. Why is this topic so important to you, and what are today's participants going to walk away with to help improve their practice?
Well, this topic is pretty important, not just to me, but it's really important to the field of speech-language pathology. The reason is that, and I do talk about some of the significance in the talk, but informally now, there have been some concerns about the extent to which speech pathologists are versed in swallowing physiology, and of course, as you can imagine, the downstream effects on their treatment and diagnosis decision-making. And while it might be fine to say, we'll just go back and learn that physiology, when you're a busy clinician who is actively seeing patients for whom your knowledge is critical, it's not that easy to go back and spend hours and hours learning about this. Mm-hmm. So I really view this as an opportunity to address some of those issues. And I think that's why it's so very important, because it directly relates to people's clinical decision-making, but sometimes they need a little bit of help working through the material.
Wonderful. Well, let's go ahead and get started. I cannot wait to hear more. This sounds really exciting. Let's begin.
Okay. Well, thank you for the opportunity to participate in this ASHA Connect teaser. As was mentioned, my name is Ianessa Humbert, and I'm an associate professor in the Department of Speech, Language, and Hearing Sciences at the University of Florida. And so I want to be sure to highlight my financial disclosures. I received research funding from the National Institutes of Health, as well as from the American Heart Association and the ASH Foundation. ASHA will be paying for my travel and providing me an honorarium for this ASHA Connect talk. I received salary from the University of Florida, and I also received royalties from Northern Speech Services, MedBridge, and a company called Element. I just want to jump in and say that the goal of this talk is to jumpstart clinician knowledge of swallowing physiology and its application to dysphagia diagnosis and treatment. So as mentioned before, the subtitle is Clinical Application to Swallowing Physiology into Diagnosis and Treatment Decisions. But I feel that it's necessary to indicate why this topic is being discussed. First, there have been calls for a shift in the practice patterns of speech-language pathologists, or SLPs, in dysphagia management, and this has occurred both in published and in unpublished forums. So these include calls for better understanding and clinical application of swallowing physiology. Also, many expect clinicians to apply critical thinking skills when incorporating the principles of swallowing physiology into diagnosis, treatment, and documentation. Importantly, there is a need because many new and seasoned clinicians anecdotally report little training on swallowing physiology and its clinical application. So that tells me that there's a need to jumpstart clinicians' knowledge in swallowing physiology, as well as both formal and informal training that's needed to help apply critical thinking when incorporating swallowing physiology. So you might be wondering how we might do this. Well, there's a long-term approach that I'm going to suggest and a short-term one that I think we can address in this talk. One long-term approach is to consider online forums. One that I'd like to talk about is a brand new resource called the Swallowing Training and Education Portal. It's also known as STEP, which can be found at stepcommunity.com. And just so everybody knows, the visuals and many of the concepts are excerpts from much of the larger material that you can find on that website. Another how is for the purposes of this teaser, is to discuss how we can jumpstart clinician knowledge in 4 important steps. So the first one is what sometimes seems obvious but needs to be stated, which is know what is normal. Now that's easier said than done, excuse me, in maybe walking and eye movement before we've ever become an expert or anyone's become an expert, a PT or an ophthalmologist. People can tell if somebody's movements are off when they're walking or if one eye's looking in a different direction. So they often know what's normal and abnormal. But with swallowing, we rely heavily on formal education in undergrad, which is when we're supposed to understand the basis of normal, to educate us on what normal is. So each swallowing event has normal parameters. And what are the swallowing events of importance? Well, they include posterior lingual propulsion, also known as base of tongue retraction, the swallow trigger, velar elevation, laryngeal vestibule closure, pharyngeal contraction and shortening, and upper esophageal sphincter or UES opening. Each of these has pretty intricate bases for how they function. And we don't have time in this talk to go over each and every one, but if you would like to get a more in-depth review of physiology of each of these events, you can do so through STEP. There's a resource called SNAPS, which is Swallowing Neuro Anatomy and Physiology Shorts, and it stands for, it allows you to see in a short amount of time some of these important events. And the normal swallowing events is where you can learn about each of the ones that I just described. But for today, we're going to talk specifically about laryngeal vestibule closure. As you can imagine, closure of the larynx during swallowing is critical for keeping food out of the trachea and lungs and directed toward the esophagus. Laryngeal vestibule closure is multifactorial. It occurs due to epiglottic inversion and arytenoid movement. Specifically, forward pivoting to the base of the epiglottis and adduction. Contributing to epiglottic inversion, important swallowing events include posterior lingual propulsion, pharyngeal constriction and shortening, and hyolaryngeal excursion. Posterior lingual propulsion occurs due to forces from the intrinsic and extrinsic lingual muscles. Pharyngeal constriction and shortening relies on the constrictors and pharyngeal longitudinal muscles. And hyolaryngeal excursion relies on the pharyngeal longitudinal muscles, the thyrohyoid muscle, and the submental muscles. Adduction and forward pivoting of the arytenoids rely on small structures, specifically the intrinsic laryngeal muscles. Now let's look at a video of epiglottic inversion, which is shown here to be complicated but important. Here's normal epiglottic inversion. We can see the epiglottis here is upright during breathing, and it inverts or folds during swallowing. Here it's completely inverted. So since the epiglottis is part of the larynx, laryngeal elevation moves the epiglottis up via its attachment to the thyroid cartilage, known as the thyroid epiglottic ligament. And it's shown here. So at the start position, before the swallow, we can see the epiglottis elevates, as does the whole larynx. So laryngeal elevation moves the epiglottis up since they're one and the same. Laryngeal elevation then allows the epiglottis to get closer to the base of tongue, which helps to fold the epiglottis down. So the epiglottis also inverts or folds because of its attachment to the hyoid bone, which moves in the opposite direction via the hyoepiglottic ligament, which is shown here. So during the swallow, the base of tongue pushes the top part of the epiglottis down, and folding mechanism is enabled by this ligament that is between the base of tongue, hyoid, and the epiglottis, which are moving different directions. So what about the free tip of the epiglottis? Well, it needs to go to the level of the arytenoids, and pharyngeal pressures help with that. The arytenoids are here, and the pharynx is here. After the base of the tongue has pushed the epiglottis down, the pharynx moves the free end of the epiglottis toward the arytenoids. So now let's see everything together. So the main point is that epiglottic inversion occurs due to contributions from the larynx, tongue, hyoid, and pharynx. This probably explains why something like an effortful swallow treatment has been shown to increase the duration of laryngeal vestibule closure. We're hoping that it also explains why understanding normal swallowing helps you to identify impaired swallowing and select an appropriate treatment. So now let's look at a video of X-ray moving, which would be video fluoroscopy, and showing here a normal, healthy individual who is swallowing. Now some of the structures are the hyoid, thyroid, cricoid, tongue, pharynx, epiglottis, and arytenoid. Now they're much more difficult to see here compared to the schematic, but with the trained eye you get used to it. So let's review that swallow again in slow motion. So step one was complete. We've just finished it, and we now know what's normal for laryngeal vestibule closure. Let's move on to step two. Step two is to identify what is abnormal, and we're asking in particular, is a specific component of a swallowing event a contributor? For laryngeal vestibule closure, we need to examine whether there is impaired epiglottic inversion, impaired arytenoid movement, or both. Let's stick with epiglottic impairment as an example and consider this case example of patient number one. Patient number one is a 68-year-old female who is status post-radiation therapy to the tonsils. Let's view her swallow. This is thin liquid cup sips. The base of tongue does not move the epiglottis posteriorly, and that's shown here in slow motion. The epiglottis is actually moving forward. But why is it moving forward? The pharynx is pushing the epiglottis anteriorly because the tongue didn't first move the epiglottis down and back. So based on this video, we can see that one deficit is that is impacting her poor epiglottic inversion is posterior lingual propulsion, for which the intrinsic and extrinsic lingual muscles are responsible. So now that we've completed step two and identified a specific component that is abnormal, we can move to step three. Step three is to understand the intended treatment effects on physiology. So just to be clear, we're still probing the swallow. We're not jumping to treatment, but we're probing which treatments seem to have a more effective or preferable effect on the particular structure that we're trying to modify. So in particular, we want to apply critical thinking, and we must consider whether research supports treatment for a particular physiologic target. So that's how we're going to know which treatment ideas we're going to probe during this diagnostic period. So for epiglottic inversion, do specific strategies or have specific strategies been shown to be effective in research? such as bolus modification, effortful swallow, and positioning. So if they have, we can determine whether or not they manifest similarly in the patient who is in front of us. So let's consider here patient number 1 with radiation treatment and view her swallows where bolus modifications are being tested in an attempt to probe the physiologic impact of research-supported strategies on her epiglottis. So this is thin liquid, and we can see there's aspiration between the swallows. So we're moving up in thickness with the idea that a heavier bolus will help to pull down the epiglottis further. And that's nectar-thick cup sips. Now we're moving on to honey-thick cup sips. Nectar didn't seem to be very effective. Now we're moving on to pudding because we can see here that a heavier bolus does push the epiglottis back and down prior to the swallow. In this case, the pudding seemed to be more effective. However, during the swallow, unfortunately, the epiglottis did not completely invert. In fact, it ended up leaving a lot more residue on the back of the tongue, just behind the epiglottis, which seems to be clutching the bolus because it does not completely invert. Now let's view whether effortful swallows are effective in the same patient. We'll begin with honey-thick cup sips without the effortful. So we're combining a heavier bolus plus an effortful swallow. So this is the honey-thick cup sip without an effortful swallow. And we do get just some horizontal movement of the epiglottis, but not complete inversion. Now here's a honey-thick cup sip with an effortful swallow. A little bit more epiglottic inversion, but not complete inversion. So we're seeing minimal effects with a thicker bolus plus an effortful swallow. Altogether, they're not very effective. Now let's review still shots of the maximum epiglottic displacement across the swallows of patient number 1, beginning with thin, nectar, honey, pudding, and finally, honey with effortful. Overall, when we consider forces from the bolus weight and from nearby pharyngeal and lingual structures, the effects were minimal on completely inverting the epiglottis during the swallow. So now let's move to a different case. Again, this is an epiglottic impairment example in patient number 2. This is a 52-year-old male who's had a stroke. So we're going to begin by viewing his swallows. In his swallows, we start out with thin straw sips. So we can see the base of tongue moves the epiglottis back in the slow motion, but it does not move the free end of the epiglottis completely down. It's the pharynx's job to do that. And there's a tiny amount of aspiration. Now let's look at an effortful swallow plus this thin liquid bolus. The thin plus effortful swallow was not effective in targeting the pharynx. So the bolus enters the airway before swallow onset on that effortful swallow. But again, it's a small amount. So what do we need to do to invert this patient's epiglottis? Well, as you know, the tongue moves the epiglottis to a horizontal position for the most part, but space is needed to allow the pharynx to do its job. So a chin tuck might allow some of that space to take place to allow the pharynx to help to completely invert the epiglottis. So let's look at a chin tuck in this patient. Swallow number 1, then number 2. Now let's look at it slowly. In the second swallow, we can see the epiglottis completely inverts, and you can see it flipping back up. Now let's move on to a heavier bolus without any strategies like an effortful swallow. We can see here the nectar bolus does not help to weight the epiglottis very much. So let's try a nectar bolus plus an effortful swallow. So we're combining weight and effort. And we can see we have full epiglottic inversion there. Let's look at that slowly. This is a large nectar bolus plus an effortful swallow. Where the nectar alone didn't work, what we're seeing here is that the nectar plus the effortful swallow was effective in completely inverting the epiglottis. Now let's look at just honey, which is an even heavier bolus, and we can see the patient is able to achieve complete epiglottic inversion. So it was effective. Now we see cracker plus pudding, which was also effective in inverting the epiglottis. An even heavier bolus, which is pudding alone. You can see the epiglottis is weighted down, and it's completely inverted during the swallow. So, based on this video, we can see that one deficit that is impacting poor epiglottic inversion is pharyngeal constriction and shortening, for which the constrictors and longitudinal pharyngeal muscles are responsible. Again, let's review still shots of the maximum epiglottic displacement across the swallows of patient number 2, beginning with thin, then nectar, honey, cracker plus pudding, and pudding. We can also see displacement for thin effortful, nectar effortful, and thin with a chin tuck. Overall, when we consider the effects of bolus weight from nearby or forces from nearby structures and positioning, each in some way was effective in completely inverting the epiglottis during the swallow. But it begs the question, why were these strategies more effective in the stroke patient versus the radiation therapy patient? Well, when patient number 1 had radiation therapy to the tonsil, and some of that radiation may have impacted both the base of tongue and perhaps even the epiglottis, making it fibrous or hard. So, despite sending central nervous system signals to target the organ, in this case we're talking about the tongue, fibers of the tongue are unable to be innervated, likely due to fibrosis from the radiation treatment. So in this case, the source of the problem is peripheral or structural. Conversely, in patient number 2 who had a stroke, the central nervous system was impacted. Still, the central nervous system was capable of sending signals to the pharynx to modulate its behavior. So finally, step 4 is to consider treatment recommendations. So the goal should be to achieve the greatest impact and to have the greatest possible patient adherence to the plan. This means that clinicians must have a continued dialogue with the patient where the recommendations are explained and patient concerns and preferences are truly considered. In our examples, we probed more than one option. The clinician should educate patients about these options and their effects and avoid deciding for the patient whenever possible. So, patient number 1 happened to indicate, I need to have thin liquids to take my medications and my mouth is dry sometimes too. She also said, I'm worried about choking. I've had the Heimlich done on me. So physiology and modifying it is not necessarily the primary goal for this patient. It just can't be given how minimally all of our strategies seem to impact her epiglottis. So we just have to make peace with the idea that for this patient, the ultimate rehab goal of restoring swallow function to a normal model might just not be possible because none of our strategies were effective. So restoration of swallowing function might not be possible, and clinicians often have to make peace with that. However, we do still have important goals that we can address, including hydration, nutrition, and quality of life outside of the SLP's therapy. And this is possible to achieve because in this patient, aspiration was negligible. It is also notable that water aided removal of residue that could not be cleared after multiple swallows. So there's a realistic possible strategy involving liquid washes between swallows that while they do not completely invert the epiglottis, since this patient seemed to have minimal aspiration, it increases hydration but still clears residue. So our recommendation, or a recommendation that could be considered, is to continue with a regular diet. This means that the patient continues to have thin liquids to encourage pill taking as well as hydration, as well as the necessary nutrition that comes from eating across a wide variety of bolus viscosities. Also, we would educate the patient to be thoughtful about the fibrous types of solids that could get stuck that may have induced her previous choking hazards, such as meat. She might consider taking smaller bites and using liquid washes. Importantly, we were able to show her that chewing properly could make a big difference. We pointed out that she has very few occlusal surfaces with which to chew and really break down food. So making her more aware of that hopefully increases her quality of life and that she can have a regular diet, but also hopefully keeps her safe from major situations where choking hazards can be a factor. For step 4 treatment recommendations for the gentleman who had a stroke, he was very motivated and willing to adhere to therapeutic recommendations, saying things like, I'll do what you say, doc. So he was a patient where the prognosis for physiology to be addressed was positive. Bolus modification, effortful swallows, and the positions were all effective. So we have an array of possibilities that we can recommend to him. So restoration of swallowing function might be possible. And the patient's acute stroke status makes him a good candidate for improvements in spontaneous recovery and for his motivation for a possible better outcome. Now, of course, it doesn't mean that hydration, nutrition, and quality of life are not important, but this patient fortunately also had aspiration that was negligible. So some recommendations to consider are to allow this patient, who at the time was not taking thin liquids, to begin consuming thin liquids. Part of the reason is that this patient needs to practice with the more challenging bolus types. We would encourage multiple swallows, and in the event that the patient finds himself coughing or throat clearing and that becomes irritating, while we wouldn't want to discourage these reflexive responses to protecting the airway, we did find that the chin tuck with a thin liquid seemed to prevent aspiration. So he might consider maintaining thin liquids with the combination of a chin tuck. So the theory behind this recommendation is that we need to have the patient practice swallowing with challenging bolus types. And this is possible with this patient because the risk for aspiration is pretty low with this patient. So again, the title was bringing it back to this idea or this topic or concept of clinical application of swallowing physiology and diagnosis and treatment decisions. So hopefully we have learned something more detailed about the epiglottis, and that is to think of the epiglottis as a weather vane, because its movements or lack thereof suggest forces from other structures. The other structures require the clinician to understand physiology beyond what can be seen on video fluoroscopy. In this situation, the muscles are the forces in many circumstances on the structures that we want to see move. And as a result, we have to understand what those muscles are, as well as their cranial nerve or spinal nerve innervation. As an example, one that we did not include in our breakdown of the forces of the control of the epiglottis is the area epiglottis muscle, shown here in pink, which courses between the arytenoids and the epiglottis. Contraction of this muscle brings the epiglottis down and back, especially during swallowing, while pivoting the arytenoids forward. So who knew that epiglottic inversions could be so intricate? And epiglottic inversion highlights how important it is to understand both normal and disordered swallowing physiology. So in summary, step 1 is to know what is normal. Step 2 is to identify what is abnormal. Step 3 is to understand the intended treatment effects on physiology while probing. And then step 4 is to share those treatment recommendations with the patient, considering that physiology may or may not be able to be completely restored. So we can apply these steps to any impairment and to any treatment.
Thank you, Dr. Humbert. I look forward to hearing more from you at the ASHA Healthcare Connect Conference in Baltimore. That is in July, and we really feel very fortunate to have you share the information with us today. Thank you again, and we hope to see you at another webinar soon. Goodbye for now from the ASHA National Office.